So I'm not sure how the next mini practical, which is not this week. All right, so Tanya, the mini practical is not this week.
Okay.
The mini practical is not this week, right? So I know you need to be told multiple times, especially about the SAT, right? So next week, there will be a mini practical. I'm not sure exactly how I'm gonna divide it, and it's going to be significantly harder than any other mini practical.
Oh
Okay.
my gosh.
Next week.
Is it worth 1 point?
No. All right, there's significantly more material. I said at the start of this class that you guys did great on the last exam. I'm very happy about that. But don't stop working yet. You ain't done yet. Okay? So that mini practical, Tanya, which is not this week, it's next week. Okay? So she was lamenting that you guys got 15 different emails about the SAT, which is October 23rd. I told you the SAT is October 23rd because the SAT is October 23rd. And people are going to forget. Someone's going to forget. Douglas is going to say, hey, well, no one told me that. No. But the point, though, is that the mini practicals are going to have 2 parts to it. One part is going to be joints and articulations and movements. That's one part. And the other part will be muscles, identifying muscles. Okay, and we'll get to the muscles next week. Now, what joints and articulations? The joints and articulations that I talk about today. So this part, beginning in slide 37, those will be the ones. There'll be others. There's certainly others that are easy to ask, but that would be for the exam.
Tibiofibular joint.
Excuse me?
Tibiofibular joint, like those joints.
Exactly, right? So if I talk about that stuff today, it's something that I could ask for next week, okay? Now, in terms of the first one that we're gonna talk about is the TMJ, or the temporomandibular joint. Once again, look at these articulations or these names, and the names mean something. So the temporomandibular joint, so it's the articulation between the temporal bone and the mandible. Where does it happen? It happens anterior to the external acoustic meatus. Talk about it being an ellipsoidal joint there. There's a disc of fibrocartilage. That disc of fibrocartilage is called an articular disc, and that articular disc is unique to the TMJ. It allows for the movement is depression and elevation. And then if you have a disorder there of the TMJ, the temporal mandibular joint, you can have orofacial pain right there. So what does it do here? The only thing that it allows for this class, the only thing we're going to do is depression and elevation of the mouth. Wait a minute. Depression and elevation of the mandible. Okay, I want to be specific. So that's the first example of the joint. There are ligaments that are helping keep this thing intact. So the stylomandibular ligament. What does the stylo mean? The styloid process of the temporal joint and then the mandible. There's a lateral ligament and then the sphenomandibular ligament. Now, is the sphenomandibular ligament going to be external or internal?
Internal.
It's going to be deep, and if you look where my pointer is right there, the sphenoid bone at that point, the only place that you can get to it is inside deep to the head, deep to the bone. So there's the stylomandibular ligament right here, and then the lateral ligament. So these 3 ligaments there are things that I might ask about. We talked about the intervertebral disc last time in last unit, so it's easy for me to ask about that. But in particular here, the intervertebral disc is one example of that. We've already talked about the nucleus pulposus and annulus fibrosis. I'm not going to really focus on that stuff. Okay? I won't focus on that, but I might focus on these questions here. So they're intervertebral ligaments, or ligaments that will hold the vertebrae, different parts of the vertebrae, intact relative to one another. So you more or less want them in a single line, not quite on top of one another, but pretty close. So that if you look at this one right here, there's 1, 2, 5 ligaments right here. So the ligamenta, or the ligamenta flava here, it's connecting lamina of the adjacent vertebrae. So ligamenta flava right there. The posterior longitudinal ligament the posterior longitudinal ligament. Now this part right here, posterior to what? Posterior to the body of the vertebrae. There's the anterior longitudinal ligament, and that's, as the name would indicate, anterior to the entire structure. Interspinous ligament is posterior, right there. And then there's this one is hard to sort of identify, the supraspinous ligament. It's going to be so there's an entire ligament that basically is superficial to this. So of the four, or of the five, the first four are easy for me to ask. The fifth one is sort of hard for me to ask. Another example of a joint, the sternoclavicular joint. We talked about this already. What are we joining here? We're joining the manubrium and the clavicle, the sternoclavicular joint right here. And then there's also an interclavicular ligament. That interclavicular ligament, there's a ligament that connects the two clavicles together, and then the sternoclavicular ligament is the one that will connect the two bones, the sternum and the clavicle. There's two joints that have a ton of mobility. They're both ball and socket joints, the glenohumeral and the hip. The ball and socket joint here allows for, we're going to say for the glenohumeral or the shoulder here, the only thing it allows for is circumduction, which really is a combination of a whole bunch of other movements, but we're just going to talk about that. I mentioned that articular cartilage can come in a couple of different varieties. The example, a labrum is an example of really, really substantial articular cartilage. In this case, it's so substantial, it's fibrocartilage too. It is built up along the rim of the glenoid cavity in this case. So the glenoid labrum is basically meant to keep the head of the humerus from impacting the scapula, and that joint capsule there basically provides for attachment right there. So the glenoid labrum is unique to the glenoid cavity. There are a bunch of different bursar sacs, and two of them are the subacromial and the acromial. What are we talking about here? The acromial process here. So the subacromial and the subscapular. At this point, I won't ask you, we won't worry about the rotator cuff muscles, but generally speaking, the rotator cuff muscles, they allow for the movement of the humerus and circumduction, and then the other things too. But the rotator cuff muscles attach to the scapula and then the humerus, the proximal portion of the humerus. And we've already talked about dislocations. So let's talk about aspects of the glenohumeral joint, or the shoulder joint. So there's the subacromial bursar here, which is inferior to the AC joint. We've already talked about the AC joint, the acromioclavicular joint here. That AC joint is basically, if you put your hand on your clavicle and you go all the way to the end, and then you find a little bump, and then you go a little inferior to that, that's right about where the subacromial bursar is. And then there's a series of ligaments. These are just a couple of the ligaments that I might ask about. And if you look at the names should tell you something. So remembering about the scapula, you should remember the names here. So the AC ligament here, or the acromioclavicular ligament, that's the ligament that connects two bones. The acromion process in the clavicle, and the coracoclavicular ligament is again two bones. Now look at this one right here. The coracoacromial ligament is two processes, a ligament between two processes, and so far I've just talked about ligaments between two bones. In this case, there's two processes on the same bone. So this ligament here is helping form the glenoid cavity. And then the coracohumeral joint or ligament is the coracoid process in the head of the humerus, and the glenoid humeral joint is the humerus in the glenoid cavity, and basically the glenoid cavity being the scapula. So all of these ligaments here are going to be attaching two bones, except for this one, the coracoacromial. So here's pictures. with lots of diagrams here, and I think I have them blown up. If you look in the lower left-hand corner right here, or lower right-hand corner, I'm sorry. This part right here is the space between the bones and where my pointer is. And once again, if you don't have any space there, then that's a problem. I think that I have all of the important ligaments underlined in this diagram. I may not, but there's definitely some. So I said some examples. So here's like the transverse humeral ligament. I definitely don't need to know that, right? There's other things that you should know about in addition to these ligaments. So the acromion process, the subacromial bursar, obviously the clavicle here. So focus on, so when you look at this diagram here, if we needed to know it from the last unit, we need to know it for this unit. If I mentioned the ligaments in the previous slides here, then you need to know it. And then finally here, if you look down here in the lower part here, there's the triceps brachii muscle, part of the biceps brachii muscle, and then there's other parts of other muscles here as well that we'll get to later on in this unit. The elbow. Now we're at the cubital joint, or the antecubital region there is anterior to the elbow joint. So the elbow or the cubital region. The humeral ulnar joint. There's the humeral radial joint, and then there's the proximal radial ulnar joint. So there's 3 articulations right there, and this hinge joint there is pretty complicated. I could ask about the capitulum and the trochlea. I could ask about the head of the humerus, the head of the radius versus other parts of the radius. So the rounded head of the radius. What does the rounded head of the radius afford the body? It allows the movement of pronation and supination. So that if you can do this with your arm, and I hope that you can, then that is due to the shape of the head of the radius. In terms of the articulation itself, there's 3 main ligaments here. There's the UCL, the RCL, and the radial annular ligament here. So these terms, collateral ligaments, in my drawing, I mentioned the term collateral ligaments. And a collateral ligament is superficial to the 2 bones. In this case, the ulnar collateral ligament is superficial to the humerus and the ulna. The radial collateral ligament is superficial to the radius and the ulna. And then an annular ligament is a ligament that's at an angle. So these 3 ligaments right here are shown. This is a medial view, and this is a lateral view. So this lateral view here, you have this annular ligament that is at an angle. The UCL, or the ulnar collateral ligament, for baseball players and pitchers in particular, in the 1970s, there was a pitcher named Tommy John. He was a really good pitcher, I think, for the Los Angeles Dodgers, and he had an injury in his elbow. His injury was the doctor dreamed up a way to take an old ligament from somewhere else in his body and put it in his elbow and replace it at this UCL, where my pointer is. The UCL, the ulnar collateral ligament, basically, if you're throwing something and your elbow goes in front and then you try to snap your hand forward here, there's a whole ton of pressure right here. That pressure that is put on there by that, again, repetitive motion here, that ended up tearing the UCL. The reason why I'm bringing up this guy is that now, that used to be a career-ending injury. Now, then with this surgery, it's now called Tommy John surgery. You have players that come back after about, I think 6 months, certainly a year after that. So it takes a long time in recovery, but that ulnar collateral ligament is pretty easy to identify. Another thing to remember here, the interosseous membrane that I have underlined as well. And no, remember anatomical position. Which, hey Diana, which ligament is going to be medial and which one's going to be lateral, right? And it's based on where in anatomical position. So the radial collateral ligament versus the ulnar collateral ligament. The names of the articulations, there's lots of names of articulations in the hand. So there's intercarpal joints, right? There's also proximal radiocarpal joints, proximal carpal ulnar joints. There's carpal metacarpal joints, and the carpal metacarpal joints would be distal carpals. There's the metacarpal phalange joints, just as the name would indicate, and then the interphalangeal joints. If you look at these first two, there's radiocollateral ligament and the ulnar collateral ligament. Wait a minute, you've already used those same terms, right? So the wrist and the hand have RCL and UCL as well. The difference, so that if I were to ask a question, I would have to distinguish between the fact that it's part of the wrist or the elbow with the UCL or the ulnar collateral ligament or the radiocollateral ligament. Once again, that collateral here is superficial and at an angle. Anything with palmar here is going to be anterior here, so the palmar is associated with the palm, again, anatomical position. That's connecting carpals to the radius here. And then the dorsal radiocarpal ligament here is going to be posterior. Dorsal and posterior are the same here. Looking at the carpals themselves, there's the scaphoid and the lunate are examples of things that you have to remember. So basically, if you remember them as associated with these ligaments, and then any other carpal is not part of this process. I mentioned with the shoulder the concept of a labrum, that really deep fibrocartilage that is a rim that prevents the head of the humerus from contacting the scapula. Here is another example of a labrum. In this case, the acetabular labrum is a rim of fibrocartilage that prevents the femur from contacting with the os coxae. So that acetabular, along with that, there's an acetabular ligament that helps connect the two bones together, or really the four bones together. One difference between this, because of that ligament and that major structure there, there's much less mobility in the hip joint than there is in the shoulder, but it's much stronger. Pictures. On the left-hand side, we have a drawing right here, and we can see the ligament on the head of, bless you, on the head of the femur. You can see an x-ray of this, and you can see, once again, when there's space between the bones, that's what is expected, and that's what you hope to have. So there's a bunch of different ligaments, and they're hard to identify. Generally speaking here, we're going to talk about a few of them in particular. The iliofemoral ligament will connect the femur with the ilium, the pubofemoral, the pubis and the femur, and the ischiofemoral, the ischium and the femur. Which of those will be posterior, medial, and anterior, lateral here? That's going from ischiofemoral to iliofemoral. So there's a lot of ligaments there, but I go pretty light on that because they're so big and they're so hard to identify. They're not easy to sort of separate. The knee joint is another example here. Once again, we have the knee joint here with collateral ligaments, and there's a collateral ligament on the medial surface and a collateral ligament on the lateral surface. The lateral one is the fibular collateral ligament, and the medial one is the tibial collateral ligament. In the knee, unlike the hip and the shoulder, where there's labrums, there's something called a meniscus. The meniscus is another version of this really dense fibrocartilage here. That fibrocartilage, which is basically these articular discs, and they reside on the cavity created by the tibia, and that lateral and medial meniscus is basically present there. In between those two menisci is the intercondylar eminence. And that intercondylar eminence there is that little projection, that super projection in the tibia. That intercondylar eminence then affords the capability of, there's really three, but we're gonna just talk about two, what are called cruciate ligaments. You know, there's cruciate ligaments, and those cruciate ligaments go in an X, and if the one that's anterior is called the ACL and the other is the posterior is called the PCL. So now it's really important to recognize which direction you're looking at the knee. If you're looking at the knee, if I say that you're looking at the knee, the right knee, then you are looking a posterior view of the right knee, then if you're looking at that, then that you would first see the posterior cruciate ligament. If you see the patella, then the first thing that you would see is the anterior cruciate ligament. Those things mean something. They, if you ever hear about, one of these students here showed me a gruesome injury in football. Yeah, another injury that's pretty common is
It was not
ACL
gruesome.
tear.
It was not gruesome.
It
It was not that bad.
No, it definitely could be worse.
I feel like
What?
I feel like that picture you showed me.
It was not that bad.
I've heard many
There's no
ACL
way.
injuries.
Mhm.
I've
That-
heard many.
What, you think I photoshopped that?
Yeah.
That's a real injury, dude. I'm not kidding. I'm not kidding.
So, the injury, aside, so whether that was photoshopped or not, I don't think it was.
No,
but,
it's not.
A really pretty common injury between the knees there are ACL tears, especially the ACL tear. There's also an MCL called a medial collateral ligament, and that is more difficult to find, so I skipped that over. So again, we have those ACL and PCL, tibial and fibular collateral ligaments here. And then there's a popliteal ligament. The popliteal ligament is superficial and posterior, and basically it runs diagonally up along the posterior view of the knee. And then the patellar ligament. The patellar ligament is weird depending on where it is. So you might see the word patellar tendon. If you see patellar tendon, then it's going to be superficial or superior to the knee, to the women. If you see patellar tendon, superior to the patella. If you see the word patellar ligament, as I have right here, it's anterior, but it's inferior to the patella. The patellar tendon attaches the apex of the patella to the tibial tuberosity. But if you're on the other side of the patella, you're no longer on the tendon, but you're in the ligament. I'm sorry, you're no longer on the ligament, you're on the tendon. I'm mixed up. If you look at this picture right here on the right-hand side, in this case, we have the patella removed. So you can see some of the inner relationship between the knees here. You can see, in this case, you might be able to see, I'm not sure, I have it blown up as well. The ACL is anterior, back down here. The PCL is posterior, right here, the posterior ligament. Again, there's the medial meniscus, the lateral meniscus associated with the knee. There's the proximal tibiofibular articulation, that's not part of the knee. There's the PCL right here. And if you look at the complexity of the knee on the left-hand side, there's a whole bunch of stuff associated with that. In this case, there's the patellar ligament here, and the patellar tendon, or sometimes it's also called the quadriceps tendon. So the quadriceps, because that's associated with the muscle. We won't call it a quadriceps tendon. So on the right-hand side is posterior view, on the left-hand side is an anterior view, and that anterior view does not have has the patella missing. So that if I were to show you this picture right here without the labels and ask you, what is this thing right here? I would have to say that the patella is missing, okay, because it's not really, it's fair. If I were to show you this picture on the right-hand side, this cannot be an anterior view of the knee. So this right here has to be the PCL, the posterior cruciate ligament. It can't be the ACL. There's also a medial view of the knee that you can look at, and you can, I mentioned, there's bursar sacs that are distributed throughout all of these articulations. One of which I talked about in the shoulder here. So there's definitely some bursar sacs. There's also fat pads that I haven't really been focusing on. But the patella, there's the example of the of the cavity itself, the synovial cavity. Here's an anterior view here with the ACL. Again, now the ACL and the PCL go basically this way. They go crosswise to one another. So here are the 5 ligaments. I'm not sure why I didn't bold them all, but they're all relevant here. Here's some examples of one thing that happens. Generally speaking, if a ligament's going to get broken here, the collateral ligaments are much, much stronger than the ACL or the PCL. So the ACL or the PCL break first, and then the collateral ligaments will break. In this case, because it's coming from a lateral perspective, the medial ligament will break, and that would sort of hurt.
A little, right? A little.
And let's just be clear, I had an actual anatomical question, okay?
Uh-huh.
That's why I was showing.
Oh, okay.
I had an anatomy question.
And then here is the last articulation, is the talocrural joint, right, or the ankle. And where my pointer is the calcaneal tendon. So again, we're talking about ligaments and tendons here. Now the calcaneal tendon is gonna go from the calcaneus, it's gonna go proximal, and it's going to attach to a couple of muscles, one of which is called the gastrocnemius, another is the soleus, and there's other muscles. But what it does, it allows for this movement right here, and that movement is that or that, and in this case, I'm doing this. And then if you want to walk on your heels, then it's dorsiflexion. Do you have a question? So if you touch the back of your calf, that's attaching to this ligament right here. Yeah. So this tendon, the calcaneal tendon. Yeah.
Was it the Achilles, that ligament? Did you ever hear about the 2 ice skaters or whatever?
Tanya Harding.
Yeah.
And
Was that the calcaneus?
No,
Or
she
was-
got.
that was the Achilles, wasn't it?
She's asking about this Olympic trials. I don't know. It was in the 80s or something. And 2 women are ice skaters, and one was generally better than the other one. So the one who was struggling to get on the team paid a guy to go up to her and smash the good one in the knee with a bar.
I thought it was that she paid him to cut her Achilles tendon.
No, it was her knee.
Oh.
I'm pretty sure it was just smashed. He just ran up to her, smashed her in. He ran up to her, smashed her in the knee, and
I
then.
thought it was her Achilles tendon. I swear.
Finn, let's talk about that later. Yes.
Doctor, how are you gonna test us on the mini practical? Like, are we gonna look at the actual
Cadaver?
Uh-huh.
So Douglas just asked, how are we going to test you on the mini practical? Which is not this week, it's next week. So there's going to be 2 parts to the questions. Right? One will be the Syndaver, right? What muscle is this? What muscle is that? What joint is this? What joint is that? And then I also have some example joints. So I have a shoulder joint, I have a knee joint, I have a hip joint, right? So I can ask ligaments on those particular joints, and then I can ask the muscles too, okay? All right?
Okay.
So I'm not gonna focus a lot on the ligaments of the foot. There's a ton of ligaments on the foot. So there's a couple. There's the calcaneofibular ligament. As the name would indicate, attaches 2 bones, the calcaneus and the fibula. So is that going to be lateral or medial? That's lateral. The anterior talofibular ligament, right? That's the anterior portion of the talus. The posterior talofibular ligament, right? And I don't think I talked about the deltoid ligament. Injuries to the ankle tend to be eversion, not inversion.
You looking at my ankle?
This is the worst part of the lecture because it reminds me how old I am. So, aging, Yes, even happened to you. My daughter said to me last night, Dad, I feel like I'm getting old. I feel like I'm almost as old as you. I remember when you played old man soccer and you used to come home and cry. I was out of shape, but I played soccer a lot. I had trouble. But one of the things that, as you get older, the joints and the articulations become more brittle. The cartilage becomes less fluid. The synovial fluid amount declines, and so therefore there's greater contact between bones. The ligaments and tendons become less flexible. So your range of motion decreases, and then finally the muscles weaken as well. So basically everything's happening here. Things are really aging on the joints. We've talked a little bit about joint disorders already. Arthritis, we've talked about osteoarthritis and rheumatoid arthritis. More recently, and we talked about gout already. Lyme disease is another thing where you can get it from a tick-borne disease, a bacterial infection. And we talked about bursitis already. Final thing is a bunion is present in just one area of the body, and it's mostly present in the first metatarsal. And joint disorders. All right. So, before we go, I'm gonna let you guys go. It's about 10:30. Before you guys pack up, first thing is if you guys could put the laptops back to their original position. This week, we're gonna have a different lab. It's gonna be 2 parts. I'm going to open up some assignments that are going to be, one of which is gonna be due before next week, okay? So you guys are gonna have a LT assignment. It's gonna be due before class next Thursday. Okay, so it's gonna be open for you tomorrow, and it's gonna be due next week, and I'm not gonna let you do the lab next week if it's not due. Okay, yes? So it's a combination of 2 things, movements and experiments.
Is it gonna help you?
Excuse me?
It's gonna help you. It's meant to help you, right?
So the experiments are meant to give you an understanding of muscles and muscle physiology, because that's what we're getting into. Okay?